Actually, we are passing more than 1 year like this kind of session actually. So everybody passing very much busy schedule, but even though they are present or connected to us, so we are grateful to them. So today our DGs are actually out of office due to other official activity, but our another director, sir, Masood, he is present. So with due permission from him, we are just starting our session.
Please go ahead.
Actually, this is a follow-up case. This case last presented to us for 30th April actually. So this is the continuation phase of that case. So our headline, follow-up case of multiple nodular skin lesion, whether it is non-Hodgkin lymphoma or others. That was not. Can you see our slides?
On to the next.
Not yet.
Sure. No. Now can you see the background slide? Can you see the current slide? Background slide. Headline is background.
Background I can see. Yeah.
Okay. Thank you. So this case actually referred to hematology initially to evaluate multiple nodular skin lesion, and previous 1 year ago biopsy report revealed non-Hodgkin lymphoma, but there was no immunohistochemistry report at that time. So with this background, we just attained as a referral consultant for this case actually. So as 2 months already passed, so we have to give more information for the audience actually. So this case was 55 years old male. He was married and his occupation was business. Clinical information, he is suffering from diabetes mellitus for last 2 years, now on insulin and no other diabetic related comorbidities at that time. Patient admitted with the complaints of multiple nodular skin lesion with occasional pain, history of fever for last 1 month, and foot ulcer for last 1.5 years. So treatment history for foot ulcer 1 year ago treated under surgery department at first, wound debridement, regular dressing, antibiotic, but there was no significant improvement. Referred to orthopedic surgery department then erasure of surgery done by the orthopedic surgeon, ulcer size significantly improved, but there was discharging sinus as well. Few nodular scalp lesions were present at that time, biopsy taken, immunohistochemistry not done, and this biopsy revealed this may be a case of non-Hodgkin lymphoma. So past treatment history, then for this non-Hodgkin lymphoma report, this case initially referred to the oncology department, and he advised immunohistochemistry, but patient did not do this investigation. So no further evaluation, no further treatment for non-Hodgkin lymphoma after then irregular follow-up by the patient. So after then he received homeopathy consultation, no improvement, went abroad for foot ulcer, there was no improvement as well. New generalized nodular skin lesion gradually appeared, and some ulcerated foot ulcer also deteriorating, and then readmit for further evaluation and management. So you can see the non-Hodgkin lymphoma biopsy report actually, biopsy report which revealed non-Hodgkin lymphoma. They also advised for immunohistochemistry that was not done by the patient actually. Now, this is also another duplex study, but insignificant or unremarkable findings. we just escaping to minimize the time actually. This is the initial photograph of leg ulcer. You can see multiple skin nodular lesion, and there was a big foot ulcer. Face, there was a big multiple ulcer. Some are necrosed. In axilla, right and left, you can see the picture, previous picture actually. So for this advice,
Rumi, the slide I cannot see for some reason. It got stopped now again.
now you can you see?
Trying with two devices as well, but neither of this is connected with your screen.
Now can you see?
No,
Changing?
very strange.
आगे zoom button है. आगे आपका zoom button है.
That's okay. I have seen the slides before, so you can carry on. Yes, I have seen those.
Now, can you see the foot ulcer picture?
No, not really. No, sorry about it. That's okay. That's okay. I have seen the slides. Yeah, no problem.
So we advise for immunohistochemistry, full thickness biopsy with immunohistochemistry, serum LDH, gene expert to exclude tuberculosis, ultrasonogram, whole abdomen, if there is any other lymphadenopathy. So we advise or plan to do this kind of investigation considering the financial issue. After then, biopsy third time done on 27th April 2023, sample sent for histopathology plus immunohistochemistry if needed. Then you just see that this last histopathology report revealed that this is a case of histoplasmosis, and fungal osteomyelitis is compatible with histoplasmosis. So after then we established a diagnosis that current histopathology report revealed this is a case of disseminated histoplasmosis. After receiving this final report, patient relatives showed another histopathology report, second biopsy, and it was missed by themselves. This point you can see that bold marker that this was the second biopsy. There was a second biopsy report which revealed histoplasmosis, but patient most probably hide or ignored this report, and this report was not shown to the consultant for this last 1 year. So no treatment for this issue, patient suffering gradually increasing, and after that you can see the picture that foot ulcer and multiple nodular skin lesion. So this was the report, histoplasmosis. So observation from initial scenario, most of the time consultant cannot implement full workup and management plan due to financial constraint, poor educational status of the patient and relatives, lack of trust and belief as well, lack of interactive approach and teamwork as well. And biopsy need to be planned with histopathology. So radiology and other relevant department needs to consider immunohistochemistry and other relevant molecular tests. And current cancer management is very much difficult without definitive diagnosis, staging, and risk stratification. So this was the observation from the past scenario. Now, follow-up case, further learning and observation from the last scenario. Missing some of the clinical information, papers may complicate diagnosis, treatment, and overall management plan. That you can see that second biopsy revealed histoplasmosis, but patient lost or hide this paper, and that caused these sufferings actually. And these sufferings and gap can easily be overcome by developing central server or record keeping policy. Actually, this point I mentioned to give some message that we cannot overcome these sufferings without implementation some activity by the policymaker actually. So integrated teamwork is the best tool to avoid to provide the best support for the treatment. Everybody giving treatment properly, but we observed that there was lacking some integration for last 1.5 years. So after then we arranged a medical board or multidisciplinary approach with the histopathology, microbiology, endocrinology, foot care, orthoplastic surgery, dermatology and surgery, medicine. So we arranged a multidisciplinary team approach by this hospital, by the activity of hematology department, surgery department, medicine department. After then, we plan for this case oral itraconazole, local wound care, amputation of the left foot. So photograph after starting itraconazole, you can see there is some little bit change. There is some crusting and shortening the size of the ulcer. You can see after starting itraconazole. And now you can see the real picture actually. You can see the improvement after starting the treatment. So what is this? That photograph after itraconazole. For last 1 month, patient actually receiving voriconazole. Before that, patient was on itraconazole. So this picture and the current picture, you can see the dramatic change of the facial expression actually. Now you can see, you can compare the previous one and now this one, neck. And you can see the previous one in the left corner and the current one is the right corner. That is the multiple nodular, ugly looking, you can say, but now the improvement of the patient condition. And this is the left axilla and now the current picture of the left axilla after treatment. And this is the picture just after the amputation of the limb. Now there is no further progression of the disease, rather improvement. So this is the message, happiness and achievement of hematology department. This is the actually our happiness due to we can take part to end a long journey of the diagnostic dilemma. This is our happiness and our achievement. We can say that we took the responsibility and we find out the real case, real diagnosis, the real scenario. And we can take part to establish a final diagnosis. We can take part to build MDT approach by the relevant department. This is our success. This is our happiness. This is our achievement, that we can incorporate all the relevant departments. Now you can see the outcome and improvement of the patient. And we can take part for this significant improvement after, we can take part for this significant improvement after the treatment. So now this patient actually handled by the medicine department and the dermatology department and the surgery department. Now active involvement from the hematology side actually stopped. They are now dealing this case and you can see the outcome. And we are happy that we can be a part of their active management actually. So this is in short about the case scenario, some lackings and what we should do to minimize this effort. Now the session is open for the interactive session discussion by the expert panelists. Thank you all.
Thank you for nice presentation and successful treatment by rare cases so far I know. Any questions?
If I may make a comment, so I know histoplasmosis is not a straightforward diagnosis. I remember when I was in Royal London Hospital, an ID registrar many decades ago, we had a returning traveler from Bangladesh was hypotensive and spiking temperature. And it took us about 1.5 months to make the diagnosis of disseminated histoplasmosis. Was your patient immunocompromised? Because histoplasmosis is a self-limiting condition, as you know. It's found in the spores and on the ground, etc., and bird species. It's very common in the environment. For a person, well person, to have a histoplasmosis is a bit unusual. Was your patient diabetic?
Yes,
And
we try to find out in this case whether he is suffering from any immunosuppression or immunodeficiency, HIV or other tests already done, but all revealed negative, that is no disease. Only we can find out that this patient suffering from diabetic mellitus for long duration actually, for long duration. And this is only the disease that can cause immunosuppression. Otherwise, we did not find any other issue related to this disease.
yeah, so that our patient was quite hypotensive and the patient had the feature of Addison's disease. And it was quite difficult until we did a scan, and patient was vomiting and lots of hiccup as well. So we were thinking of uremia and the intra-abdominal pathology. So everything was done. All we found is bilateral adrenal hyperplasia, a bit bigger. And subsequently, the adrenal biopsy actually confirmed the histoplasmosis. So that diagnosis, to be fair, sometimes can be very, very difficult. And our patient, obviously, we started Embizone and subsequently itraconazole and did very well. He's a Bangladeshi man, actually. he was diabetic as well, and successfully he has done well. Last time he was followed up, it's about 10 years ago now.
Thank you, sir. Any advance in detection or diagnosis of the histoplasmosis, like blood antigen, urinary antigen?
So, as you know, the San Diego immunoassay is very sensitive antigen test. As they've been, I think it's been in the market since 2008. It's very sensitive test. So you can do the antigen test, ELISA test, obviously the culture, and under microscopy of the tissue, where your patient's been diagnosed of the Crocott immunostaining, the typical H&E staining, you can't see the histoplasma, so you need a special immunostaining, which I'm sure has been done on the biopsy sample. And now you can do the, obviously culture is positive because it's a fungus, isn't it? So you can do the culture, you can do the antigen test, ELISA test for serological test as well. So we can do that. But typically, our patient and your patient diagnosis has been made from the tissue biopsy. One thing is so important, and I kept telling everyone that H&E testing under microscope, do we have any histopathologist here?
Right at the moment, no histopathologist here.
Dr. Faraiman, are you present?
Sure,
Are you
sure.
connected?
No,
Faraiman?
Yeah. Yes, sir.
Yeah.
Sorry.
Thank you,
Online.
Faraiman. I'm sure you will agree with in the microscopy, when we see a tissue under microscope, diagnosing lymphoma, myeloma, even other solid cancer can be sometimes challenging. It is fair to say that solid cancer such as breast, lungs, colorectal is reasonably easy, but hematopoietic and other diagnosis like this infection is really difficult under H&E testing under microscope, and you should be relying on, or we should all be relying on the immunohistochemistry in the right setting. I have a case discussed yesterday from Bangladesh. Is a CD5 positive, 20 positive, 19 positive, diffuse large B-cell lymphoma. But initially you will be surprised. It is, so now in the immunohistochemistry, we will come to the next stage, but the initial diagnosis was made from the neck lump is squamous cell carcinoma of unknown origin. But actually the rapidity of the lymph node, LDH and all the other markers, when the sample sent away, CD5 2019 positive, histopathological diagnosis was diffuse large B-cell lymphoma. So it can be difficult, and we do see it all the time, lung biopsy, reactive TB, granulomatous lesions. And once the patient is not better with anti-TB medication or conservative management, you go and do further biopsy and you do the immunohistochemistry and you find the surprise. So it is not uncommon. So if possible, we should encourage the patients and the relatives to embark on immunohistochemical testing in right setting. So question for Rumi actually. So this gentleman who has diffuse large B-cell lymphoma, so-called neck lump biopsy, CD519, 20 positive, and his Chi67 is about 70%. And this is diffuse large B-cell lymphoma. How would you comment? And then I will come to Farah. Do you think it's deep? And it's a germinal center type diffuse large B-cell lymphoma diagnosis have been made?
This marker may common, but the lymphoma actually proliferative marker Ki67, but it doesn't mean that this may be a case of lymphoma. This marker may positive in lymphoid cell as well, 20 or 19, but needs confirmation that this marker positivity for the lymphoma actually. So we should re-evaluate by the second opinion or other expert person as well.
Yeah, absolutely. So the problem is the patient didn't have the CT scan of the whole body, so we don't know the stage of the disease. So it's difficult. If it is limited stage, you give few chemotherapy, 4 cycle and radiotherapy. If it is systemic disease, you give 6 cycle, as you know. But the message is here that once you find a CD5 positivity in a lymphoma cell, you are bound to exclude CLL and mantle cell lymphoma until proven otherwise. Before you make the diagnosis of diffuse large B-cell lymphoma, you have to exclude these two entities because it could be CLL, it could be mantle cell lymphoma. So seeing the proliferation fraction, as you said, a bit higher and CD19 and 20, it doesn't mean anything. It doesn't mean it's diffuse large B-cell lymphoma because treatment protocol is different. But on the ground, the patient you dealing with, probably you will be appropriate to say this is a high grade or high proliferation fraction, non-Hodgkin's lymphoma, treat with DLBCL, like DLBCL, R-CHOP. But to be fair, for the trainees and the juniors and the other to understand the CD5 positive, until we say diffuse large B-cell lymphoma, I have to exclude 11-14 translocation CCND to say, look, it is not CLL and CD23 as well, and not mantle cell lymphoma, and treat accordingly. But otherwise, this patient, you see, some of these patients will go to other places, and the criticism will come to the initial team to say, oh, they misdiagnosed it, and they are right. So to avoid this, we should adopt this to say what we know and what we can do. At least say to these patients, no, we have to exclude this. We have to state the patient accordingly. And if they can't afford, that's absolutely fine. They can't do it. You have to treat what you have, use your jurisdiction, as you know.
I'd like to go for the treatment purpose. Here, Ruby and our team has done by itraconazole. But so far, I have gained knowledge that the first line of treatment is the lysosomal amphotericin B3.
This issue has been discussed in our multidisciplinary team meeting. As mentioned that financial constraint, we offer this option, but patient mentioned that we are not ready for this financial issue actually. After then considering all the issue, itraconazole comes first, and you can see some improvement, but it was a little bit poor. Then voriconazole started for last 1 month by the medicine consultant. Now you can see the outcome actually, current situation.
Obviously, as you said, this in ideal situation with a disseminated systemic or aggressive disease like this patient, we need to give liposomal amphotericin B initially, and then you can switch on to itraconazole, voriconazole, azole. But due to financial constraint, I don't think it's a bad idea to embark on the itraconazole. My experience in ID is at least 15 years old, you see, so I'm sure you will know more about the treatment. But
there is no further discussion regarding this case. We can switch the next session actually. I think that will be also very much interactive. Is there any other discussion needed? So, sir, we want to switch for the next session. Otherwise, we cannot cover.
The problem is, Rumi, I cannot see the slides. Can you log on, log out again and see whether I can see the slides?
Okay, wait.
The slide share in our share screen.
I can see something now. Yeah, that's good. That's better.
Okay. Can you see now?
Yes, I can.
Okay. So actually, this case from our renowned panelist, Dr. Amin Islam. So on behalf of him, I am just describing the case actually. So 3 challenging cases in recent month. Sir, you can tell something, I think. I just moved the slide.
That's okay. You were on the grand round in here in our, so you can talk and then we can
no, sir. No, sir. It will be much more helpful if you say something regarding the case.
Okay. So this is a very interesting case, a referral case to our University College London Hospital from North Wales. It's a very young man, as you see, 26 years, with a huge right iliac and left mastoid mass. It was growing so rapidly and was very, very painful as well. So clearly it was very aggressive something. He was a bit anemic with raised white cell count and raised lymphocytes. Platelet was a bit low, 100. is urea electrolytes were reasonably fine. LDH was slightly raised as well, and slightly raised uric acid. Obviously, with this mass and the lytic kind of destructive lesions, people initially on the original hospital did a serum protein electrophoresis and free light chain. They wanted to exclude myeloma along with other suspected cancer, and that were negative. The patient obviously, when was transferred, got a quick, because it's a bony involvement, so we thought we will get whatever the diagnosis is easily from the iliac crest bone marrow, either hematopoietic or solid cancer. We can easily target it. And the bone marrow was very heavily infiltrated. And what we found is CD20 negative, 38 was positive, kappa restricted plasma cell. So the problem now is whether this is enough data for us to say this is myeloma, because we have to embark on is a non-secretory multiple myeloma. And before we say that, we have to be absolutely sure that it is not other solid cancer expressing CD38. I know that CD38 is a marker of plasma cell, but knowing our red cell will have also CD38 marker. So that doesn't mean anything. It doesn't give you a diagnosis. But the kappa restriction is pointing towards the plasma cell neoplasm. If it was not restricted means expression for the medics and other people. Farah Imrana will know that CD38 and 138 does not make a diagnosis of myeloma, because you have to have this clonality tested, and the way we do it, a kappa lambda cytoplasmic restriction study. Otherwise, we say just a reactive plasma cell. So we wanted to exclude whether it is plasma cell myeloma or plasma cell lymphoma, and treatments are different. These two entities sometimes difficult diagnosing. So we now establish this is a plasma cell neoplasm. Is it plasmablastic lymphoma or plasma cell myeloma? That needs to be established, because treatment will be slightly different. If you see on the other marker that in plasma cell myeloma, 56 and 117 can be positive, MUM1 can be positive, and the usually plasmablastic lymphoma, they are immunocompromised and HIV positive in Western world. But myeloma obviously will, in addition, can have plasmablastic myeloma, CD56 and 11 and MUM1 positivity. We did this fish CMYC, which was negative as well. And we also did the EBV adenovirus, all came back as negative. So viral skin, you have to do a suspected cancer patient. You have to do the viral skin. Rightfully, we have done it. And you see we're all negative. So as I said, that HIV positive plasmablastic lymphoma is common, plasmablastic myeloma uncommon. Usually in myeloma, you have CD38 and 138 positivity as well, kappa and lambda restriction. And non-secretory myeloma, obviously, serum protein electrophoresis and the light chain is essentially normal. Do you want to make any comment, either Rumi or Farah Imrana, about this case immunohistochemistry and diagnostic dilemma initially? Now we have streamlined, and we know we're dealing with a plasma cell neoplasm. It doesn't look like plasma cell lymphoma. Increasingly, is a plasma cell myeloma type of pictures. Farah Imrana, have you come across any case like this on your immunohistochemistry and H&E staining? It's a rare case, though it's not very common. So you will see the key message is here, not this case index only. It's how many specialty you got biochemistry involved, looking for the serum protein electrophoresis, free light chain. That's helping you diagnosis myeloma or excluding myeloma or making a diagnosis of non-secretory myeloma. You have your hematohistopathologist here, you have your PET radiologist here to comment as well. You have hematologist here, you have clinical oncologist. Because of the mastoid pain, we had to give emergency radiotherapy to the mastoid and the iliac crest because it was not controlled with morphine patch and the pressure control analgesia as well. And after the radiotherapy, thanks to the clinical oncologist, patient was completely pain-free as well. So radiotherapy helps in cancer to control the pain, and rapidity of the enlargement can be controlled as well. Obviously, plasma cell myeloma and plasma cell lymphoma slightly get treated slightly differently. Lymphoma we treat with Arcodoxem, IBEC, hyper-CBET type of chemotherapy. And the myeloma, we give DT-PACE or other DARA-BTD type of chemotherapy is the name of the regimen. There are lots of options available. And because of the rarity of this condition, there has not been any unified global protocol. Is the availability of the protocol and expertise of the expert embarked on the regime actually. Our overall outlook for this patient is much, much inferior. In lymphoma, it's about 20 to 30% patients survives. In myeloma, it's about 30 to 40% patients survive. The rest of them dies, unfortunately. So the message here is a multidisciplinary approach. If I dealt with, as a hematologist, this case initially, and on the CD38, I would have said possibly that this is just a multiple myeloma non-secretory. And many times, the global perspective, it is very common to say, oh, there's a mass here and there are lots of aggressive looking cells that look like plasma cell, CD38 positive, and treat as myeloma. But as you know, about 26 cancer will express 38 and 138, and most of them neuroendocrine. Even we had a breast cancer patient who expressed 38 and 138 and clonal non-restricted. So clinicopathological correlation always so important rather than just relying on scan or a specialist opinion or some immunohistochemical. You need to put lots of people together. It is challenging sometimes to get everybody on board under the one roof, but at least discussion needs to happen between the specialists when I am confused with the diagnosis rather than just making the diagnosis that I know this is myeloma. And that helps us as a specialist, as a team, and the patient as well. So that's the key message from this case.
In addition to this, I want to share one message that sometimes this issue come regarding the CD45 positivity. Sometimes some cancer, we can think that is it hematological or non-hematological. This issue, CD45 positivity, may come in non-hematological malignancy as well. So regarding the CD38, 138 or CD45, it doesn't mean that we should conclude single diagnosis. We should think about the differential diagnosis as well before giving any definitive treatment.
Yeah, absolutely, absolutely. Many of the hematological cancer will not have CD45 positivity, as you know. But typically people are used to know and gating the CD45 cells in the flow cytometry labs and immunohistochemistry and others. But we have to keep in mind as a histopathologist as well as the hematologist and other specialists, then we can have so many variations nowadays. And to build the confidence among the population and the patient, it is so important for us to at least suggest, look, I don't have enough data and we need some more investigation to make the proper diagnosis. And that's the way eventually we can build up the confidence. Because this patient, some patient with the like CD5 positive previous case, he will go to Singapore and that's doctor or India say, and they will say, rubbish, this your doctor Bangladesh, they don't know anything. They misdiagnosed you. And the patient, because they traveled far away, they will believe, you see, and they will tell whole nation that our doctor, they don't know anything, which is not true. Is if we say, look, this is what you have, this is what we know. We all know, but it's how you put this in front of the patient. That's the challenge I feel. And we should always encourage rather than be biased with the patient to say, look, they can't get the treatment, they can't do the immunohistochemistry, just treat what we have. Say, yes, that's fair enough. For this previous case, what I said from yesterday from Dhaka, that's fine. If the patient said, I can't do, sir, any other test or anything, what you have, it is a high-grade lymphoma, treat me as high. That's absolutely fine. But as long as we write there, rarity, you see, this patient goes, and then doctor cannot say in India and Singapore that we have not thought on the right line. And that's, I think, key message we should always do as a specialist. What we know, we just mention it to patient, no matter whether they can do it or not.
Can we start our second case?
Before, I think,
Excuse me, before that, we have to think about the diagnosis, which is the confirmatory diagnosis, flow cytometer, or just marker CED138.
yeah. So the important thing is what I'm going to say to you about the flow cytometry. We need to have another session actually. Say a patient's multiple myeloma, Rumi is suspecting in BIHS, has got paraprotein and got light chain lytic lesions in the bones. And he has taken the fluid from the bone marrow and he is sending the sample to some other hospital, say India or Singapore or America or some other lab, where the sample will be tested 24 hours after or 12 hours after. You will always underestimate the count, either a blast or plasma cell, because the cell will die. So not a single, the flow cytometry will tell us are the clonal abnormal, but they will not accurately estimate the percentage. The reason is percentage is important. For us to make a diagnosis of MDS, we have to have less than 20% blast. 20 and above for acute leukemia. Myeloma, you see 10% plasma cell and above, but if you have below, then it is a MGUS. So no unique test can make a diagnosis, but that will be complementary. That will help us to say these are clonal plasma cell, but still a microscopy under microscope in acute leukemia and also myeloma is essential to count the percentage of the blast and the plasma cell. And now we have cytogenetics, we have NGS, you have so many things in, and you will be putting into the Trefine as well. Yes, thank you, sir.
Any other next case?
Yes, sir. Next case, please, sir.
This one, Rumi, I think this is a similar kind of patient, a diagnostic dilemma, myeloma, and this was actually a breast cancer patient, unfortunately got treated as myeloma because of the 38 and 138 positivity. Clonality was not tested and that got missed. Patient typically had the lytic lesions, patient had lots of infiltration, you will see on the bone marrow, and looked like the myeloma, but actually that was metastatic breast cancer. It's a key message for all of us here. The breast cancer is one of the cancer that can just present in sanctuary sites. For example, not anything. This patient, nothing on the breast. Mammogram was negative. She only had on the PET scan was a bone marrow-based disease and the left supraclavicular lymph node. And because of the extensive lytic lesions and the morphology and 38 and 138 positivity, people thought it is myeloma and treated as such, but actually she progressed. And when they did the repeat biopsy, because it was a non-secretory myeloma, everything got worse. And this patient was on letrozole, and unfortunately she passed away a year after. Very young patient, 56 years old. Whole life work for the Cancer Research UK. So again, it is not common cancer to have lytic lesions and bone marrow infiltration, 38 and 138 positivity, not to have myeloma. You will immediately, even if you ask a hematology, they will say it's myeloma until proven otherwise. So the key message is there are lots of cancer can express various marker which can mimic myeloma, lymphoma, other solid cancer as well. There are lots of neuroendocrine tumor can mimic like multiple myeloma as well. So for us to be sure, we should be relying on various tests together and obviously use our clinical acumen and differential diagnosis as well. So this is again not the index case, the importance of clinicopathological correlation.
So
I see.
one thing I want to share that. So this case may come with lump in the different discipline actually. So for that discipline, this is mandatory to think about the whole spectrum actually. And radiologist should think about like this way. Otherwise, he or she may comment something and the consultant may think something. After then, they can send this sample to a lab. That lab may not have the facilities to evaluate all kinds of spectrum actually. And after then, they may say that sample is inadequate, no scope to evaluate further by the other lab. Then again, BIHS or other thing may complicate the whole scenario. Patient may lose faith on us actually. So actually from the very beginning, we should think about the whole spectrum from the radiological side, from the clinical consultant, from the histopathologist as well. And we should plan for the whole scenario in an organized way so that we can reach a complete diagnosis, we can start a definitive treatment as well. Otherwise, we may see the scenario like the first one case actually, 1.5 year journey, but no diagnosis, no treatment.
Yeah, it's very true. It's challenging in our country, especially in Bangladesh. As you know, the patient takes their own responsibilities. They sometimes, due to the lack of the understanding, they might, if you say, look, you need more tests, they just disappear. They don't come to you again. They said, okay, the other doctor said they have enough information to confidently make the diagnosis. So this is a challenging situation and how to overcome. But the key thing is once we are having a patient in front of us and they are willing to embark on the various tests, etc., we should use the pathway and methodical approach. But many of your patients, Dr. Rumi, if you say, I need a PET scan for your lymphoma or a CT whole body, they'll say, no problem in the neck. Why do you need to do whole body CT? And you will not have much time to spend 20 minutes to explaining to this patient because you have other commitment and etc. The patient education is so important. So you have seen in my clinic, every week I see in the NHS clinic is about 150 to 120 patients. And no matter how difficult the diagnosis is, so simple for you to make them understand. They can be very illiterate white English man, but you say you got TPLL. I said, yes, sir, that's fine. Yeah, what next? But for you in Dhaka, to make your even highly educated people to understand a TPLL will take 2-3 days. And you really do not have this time because you have other commitment. And you kind of brush to and say, look, this is the diagnosis, this is the way treated, and he will go and disappear, never to come back. So patient education, community education, make it understand, people understand, and also build up the confidence. It's a matter of time and effort, and also national strategy is so important rather than us working in an isolated small team. To change the whole system, you need the national strategy. And I'm sure will happen one day, but I don't know when. We have to all work together. I see, I have one thing because we have to wait till next. I have one question. I think I see the medicine specialist all are here. I want to ask you an opinion about a patient who has mechanical mitral valve, and the patient has come in with platelet count 3 with some epistaxis, mechanical mitral valve on warfarin. Do you have any concern on this particular patient not receiving warfarin or anticoagulation for 2 weeks when we investigating for ITP and treating the ITP with a platelet count of 3? Do you have any comment?
As there is some bleeding and a patient is on warfarin, platelet count 3,000. So we should think about the alternative option for some period. Otherwise, this bleeding may exacerbate and life-threatening condition may create actually. From my side, this is my comment actually.
Yeah. And another comment from medicine. The worry is here from the cardiologist, cardiothoracic, and other people that fair enough, the platelet count is 3, patient is on warfarin INR in between 3 and 4, it's okay. But if we do not give anticoagulation for 1 week, the patient will have stroke and also thrombosis within the valve. And that's the reason they want to give this patient intravenous unfractionated heparin for a few days. And do you support this? And if yes, then why?
Low platelet count, if we start heparin, this may cause further deterioration, not for the all patient, but we do not know that the heparin working properly or it cause further deterioration of the platelet count actually. But coagulation or stroke not directly related with the anticoagulation, the INR 3 or 4. There are some other factors which may cause stroke actually, and short period of time stopping warfarin may not be the only one reason for the stroke actually.
Okay. So in other words, you are trying to say that mechanical mitral valve in normal situation, say my platelet count is normal, 300, and I have a mechanical mitral valve, and I want to be off anticoagulation, any anticoagulation for 1 week. Is it okay? What is the risk of thrombosis? The reason I'm saying is the cardiologists were very keen. They said, no, this patient will have a thrombosis. It's a mitral valve, more thrombogenic than the aortic valve. The risk of stroke is very high. I appreciate you are dealing with a patient's platelet count 3, give couple of pools of platelets. We said, okay, we have given 2 pools of platelets, and it came back 3 to -2 after 1 hour because it's all been destroyed. So their point is, we want to give some anticoagulation because we are hesitant the patient might throw the embolic phenomena to the brain or leg, other things, and people will have ischemic leg or other problem. Are you confident to say, don't worry, don't give anticoagulation, let us fix the platelet count fast?
Actually, we did not face this kind of situation. To give some comment confidently, I think
No, you have the case, and this is your case. This is one of your cardiothoracic center vascular unit case, and this patient typically we do come across, but unfortunately they die because we actually do not. There is no protocol you will find how to deal with it. It's just expert opinion and how multidisciplinary team approach comes together to say this patient's platelet count is now 500. But what happened, even in the West, typically the cardiologist will say, okay, give IV heparin. But the risk of bleeding with a platelet 3 is very high. Even with ITP, the risk of intracranial bleed when platelet count is less than 5 is about 20%. It's very high. Though ITP patient typically shouldn't bleed because they're functionally good platelets, they're not non-functioning. But if your patient is mechanical mitral valve with the low platelets and INR is 3 already therapeutic, and with epistaxis is a very high risk of bleeding. And if you give IV heparin, the patient had significant GI bleed and extensive ecchymosis everywhere in the body. And the heparin had to be reversed with protamine sulfate. And the patient's subsequently off anticoagulation for 2 weeks. And romiplastin steroid IVIG has been given, and platelet count went up to 500, paradoxical. So that became now challenging to treat effectively with anticoagulation. So the data is, I don't know whether we have any cardiologists there now.
Today, no cardiologist is connected.
So probably this one is a very top challenging situation. Mechanical mitral valve in pregnancy, mechanical mitral valve in bleeding patient. I think we should do another separate session and getting people cardiothoracic and the cardiologist in together, because you will have this patient in front of you, and if you can work together, you will potentially save human life. The data is there is no unique clinical study here. If you extrapolate all these hundreds of studies together, mechanical mitral valve without anticoagulation for 1 month, the risk of bleeding is about 2%. Not bleeding, the thrombosis is about just 2%. So just keep this in mind. The thrombosis risk, throwing the thrombus from the heart is very rare actually. And 1 week of anticoagulation is about 0.04%. So that's we need to build the confidence among the surgeon and the cardiologist to say, the patient has very high risk of bleeding, don't worry. There will be a small risk, but we have to inform the patient and act on the risk-benefit ratio and best interest of the patient.
So if you give permission, already time little bit there to end actually, can we conclude the session? So I'm requesting our ENT professor sir, our endocrinologist Dr. Ahmed Mir, one of them.
Thank you, Professor Amit, to be with us online. You have given a lot of information and advanced and recent information for the purposes cancer treatment or hematological treatment. Is today we have no other medicine or other faculty here. Still, it's very interesting session, and we presented nicely, and you also discussed very nicely. Thanks once again to be with us again and again. Thank you very much.
Thank you, much appreciated.
Thank you all for participation. Thank you so much.